Welcome to the monthly AKCI, KCA didactic. Sorry, I'm just letting people in here. Pleasure to have today Pavlos Msaouel from MD Anderson, who's done a ton of work in non-clear cell and what I consider like big picture statistical interpretation of trials and a lot of things. And he's going to talk to us about how to interpret randomized clinical trials, which is a good lesson I think we all can learn. So Pavlos, we really appreciate your time and expertise, and we'll turn the floor over to you. And I told Pavlos this group loves to interrupt with questions, so please do, and we'll leave a little time at the end for questions as well.
Yes, thank you so much for having me and for allowing me to present on this. And by all means, please feel free to ask questions. And another thing we can do to keep this interactive, I just put a link on the chat to answer questions that we're going to be having throughout the presentation. So the presentation today will be about interpreting randomized trials. And this is, I asked GPT-4, this is the hot thing these days, LLMs, to depict today's lecture. And this is it, there's this crazy guy. I used to have a mustache. I don't have it anymore, and a beard, but I guess it depicted me with one because that's my MD Anderson page about random musings on randomized trials. These are my disclosures, other than having various investigator-initiated trials with some companies. None of the disclosures are related to today's talk. And this is the way through which you can answer the questions that we're going to be having, either through text or through the link that I also put on the chat. And when we have questions that you can answer, we will show this again. And the objectives today is, first of all, distinguish what it means to do what we call randomization, and distinguish that from balancing covariates like prognostic factors. And we'll talk more about that. And very, very importantly, and a key objective is, how do we interpret data cleanly from phase 3 randomized trials in oncology, focusing in kidney cancer, obviously, with this group, by learning how to separate signal from noise. And so let's start. Let's start with the big one. This is, as all of you guys know, a very, very, very important practice-changing trial. Checkmate 214, a trial of nivolumab, phase 3 trial of nivolumab plus ipilimumab versus sunitinib in patients with treatment-naive clear cell renal cell carcinoma advanced. And it had the primary endpoint for overall survival, which was presented. All of this was in the abstract. So everything I'm showing is in the abstract of this very important New England Journal of Medicine 2018 trial. OS probability at 18 months, 75% with these confidence intervals with nivolumab. And it was 60% with these confidence intervals with sunitinib. And then the hazard ratio of 0.63 with these confidence intervals. And then the median survival was not reached. And, they showed the confidence intervals, noting that the upper bound was not estimable with nivo-ipi and versus, 26 months and these confidence intervals with sunitinib. All right, those are the data. So this is the abstract. You have now to read the trial. And so per the CONSORT guidelines, which you can read here, which of the following results, all of which are in the abstract of this very important trial, is most correct? 1. The 18-month overall survival probability with nivo-ipi was 75%, with sunitinib was 60% with those confidence intervals. The hazard ratio for death is 0.63 with these 95% confidence intervals. The median OS was not reached with confidence intervals here with the nivo-ipi, and it was 26 months with sunitinib with these confidence intervals, or all of the above results are equally valid. So let's see what you guys think. There, only one of these 4 answers is correct per the CONSORT guidelines, and it's not just the guidelines. We're not just following the guidelines. This is real. This is the way we need to look and interpret trials. So I'm going to give a few more seconds because we're getting a fair number of answers. Okie dokie. I am going to deactivate this now. So 50% said all the above results are equally valid. And then it was 20% chose the first one, 20% chose the second one, and 10% chose this one. The answer is this one. The hazard ratio for death is 0.63 with these confidence intervals. This is the correct answer, including per the CONSORT guidelines. And we're going to talk about this. Why? Why is this the case? So this is because of the difference between random sampling when you randomize versus random treatment assignment. What is random sampling? Well, you randomly sample patients from a population when you randomly enroll them in a study. There's no eligibility criteria, no consent. You just take them from a population and then you do whatever you want. You survey them, and then the results that you get, you can generate confidence intervals, and then those confidence intervals give you the uncertainty about the sample when you're making inferences from the sample to a population. That's what these confidence intervals means. That's what these statistical hypothesis means. But medical trials, including Checkmate 2 and 4, do not randomly sample. They use what we call convenience samples. These are the patients that are accessible to our clinic, have access to the trial, will consent, will be fulfill the eligibility criteria, etc. So this is not random sampling. What medical RCTs do in oncology and other fields as well is we randomly assign the treatment. So we have the convenience sample, we have the patients that get enrolled, and then we choose randomly which of the therapies they're going to get. So when you do random sampling, which we don't do in oncology, that licenses the estimation of uncertainty estimates like confidence intervals and p-values for group-specific parameters, like the 18-month survival probability for nivo-ipi, or the median survival for sunitinib. Then you can, when you generate confidence intervals for these group-specific parameters, the inference you're making is that you randomly sampled from that population, but we didn't. And if you didn't randomly sample, then, and you use a convenience sample, then you need to make a lot of adjustments, a lot of modeling that trials, including Checkmate 2 and 4, usually don't do. So you can be descriptive about these values, like by using things like the medians, interquartile range, etc., but you cannot make statistical inferences from the sample to the population. The magic of randomized trials, including in oncology, is that the random treatment assignment licenses the estimation of uncertainty estimates for comparisons, for differences, for comparing one group versus another or more groups. So these are, as I said, group-specific parameters are things like median survival for one group, objective response rate for one group, 18-month survival probability, you name it, for each group. Comparative parameters would be things like the hazard ratio, the median survival difference, the 18-month absolute risk reduction. So this is focusing on difference. That's what the random treatment assignment allows us to estimate more reliably. This is why randomized trials are meant to be comparative. I know it may sound quaint, but believe it or not, this has been largely forgotten in oncology. Randomized trials are clinical experiments, and their purpose is to compare interventions. And because this has somewhat been forgotten, there is now this new type of approach, which actually is becoming more and more prominent in oncology, the randomized non-comparative trials, that every time that I discuss this concept with, theoretical and applied statisticians, they're like, what? Randomized non-comparative trials? That's insane. It's insane. And yet you're going to be seeing them spreading, and they're being published, including even in the Lancet and other journals, randomized non-comparative trials, where they're not comparing, which is an oxymoron. There will be an article in the popular statistical magazine Significance in May, where we're highlighting this to the world and we're saying, hey, let's stop doing this. Or if we're going to do it, we better doing it knowing what we're estimating. So let's focus now on what RCTs truly do, which is comparing things. And the comparative metrics are going to be differences like mean or median survival differences. and their uncertainty intervals, or ratios. That's what we most commonly use, like hazard ratios, odds ratios, or risk ratios. And when we estimate these comparative metrics, the most reliable estimates are when we include every patient. So you guys know this, that every time we try and do subgroup analysis, there's a lot of issues with them. So most reliable is to look at the whole population, because the subgroup inferences are always going to be less precise. They're feasible. I'm not going to, in this lecture, because I don't have time, to discuss how you can more personalize the inferences to particular patients you see in the clinic, but it is feasible. The trick is, I'm going to allude to this, that you need to use, and this is another mistake that often happens in oncology, prognostic information, not the so-called predictive one. And I'm going to touch upon this a little bit later in this lecture without getting into much details. Because the first thing I want us to focus on, as I said, is the basics, that we care in RCTs about comparative metrics. And so, and one aspect when it comes to comparative metrics, the most common one that we use is hazard ratios. And this is a mathematical object that can be very counterintuitive, but it has certain advantages mathematically and pragmatically, which is why we use them. But it's very, very counterintuitive. Hazards, so hazard ratios are ratios of hazards, and hazards are not risks. There's something different. And it makes a big, big, big difference to realize that. So when you see, let's say, a hazard ratio of 0.6, it is not a 40% reduction in risk, because risks are probabilities and hazards are not probabilities. It's a 40% reduction in hazard. But when we are using these ratios, as you guys know, when the ratio is 1, then that means that the treatment and the control groups have the same effect on whatever is the outcome of interest. Conventionally, when the ratio is less than 1, it means that the outcome, which very often in oncology is death, is decreased. So decreased death in the treatment group compared with the control group. When it's more than 1, then the outcome is increased in the treatment group compared with the control group. You guys know this. But what is this mathematical construct of hazards? I'm not going to go into too much detail. I don't want to cause too much confusion with mathy stuff, but essentially, this is an instantaneous risk. It's not risk per cell. It's risk over time divided by time. And so in the same way that, let's say, velocity is the space you've traveled divided by time, and so space is different than velocity, in that same way, hazards or hazard rates are different than risks. So hazards are instantaneous risks. And what happens is that we assume in oncology, it's a fair assumption to make, that those instantaneous risks, the hazard rates, are constant over time. And we can model it if we don't want it to be constant. I'm not going to go into that. And then we compare them using these ratios for, let's say, one therapy, let's say chemotherapy versus placebo. And let's say the hazard was 1 per day. It's an abstract, arbitrary number, these hazard rates. It's, again, a mathematical construct helping us to do certain math. 1 divided by 2, we get a hazard ratio of 0.5. The nice thing is that under the standard assumptions that we use in oncology, if we have the median survival times for each group and we divide the medians, we also get the hazard ratio. So if the median survival was, like, let's say 10 days with chemotherapy and 5 days with placebo, that's the hazard ratio of 0.5. Now, having said that, very, very quickly, now I want us to do something else. I want us to start interpreting those comparative metrics. You know now what to focus. Comparisons like hazard ratios. And I'm going to use a trial from breast cancer. Why? Breast cancer in the solid tumor world has been the field where they've done the most work with, different subtypes, biology-driven therapies, prognostic versus predictive biomarkers. So there's a lot of understanding in that field. So I like to use their examples to gain some insights on randomized trials. So this is an actual randomized trial, phase 3 in breast cancer, and they compared metastatic breast cancer. They compared surgery of the primary tumor. They called this the LRT group versus not doing surgery, and they called this the systemic therapy ST group. Systemic therapy only. LRT got both surgery and systemic therapy in de novo metastatic breast cancer. And these are the results of the trial. They got a hazard ratio of 0.66 with these confidence intervals, a low p-value, favoring the LRT group, the surgery group. However, when you look at the table 1 of this manuscript, you see the following imbalances in the subgroups that were not stratified. So this was pointed out in the manuscript itself, and you can read it, from the PMID. So you see that the LRT group had more ER/PR positive compared to the AST group with this p-value for the differences. And we know, and the LRT group had less triple negative versus the AST group, and we know that triple negative breast cancer tends to be more aggressive than the ER/PR subtype. So with that in mind, which of the following statements now is most correct? The imbalances in tumor type between LRT versus ST suggest that the randomization worked as planned. The results suffer from confounding the bias because the ST group had more triple negative, worse prognosis, and fewer ER/PR positive, better prognosis patients. 3, the imbalances in tumor type between LRT versus ST suggest that the quality of randomization was poor with p-value less than 0.05. I'll give you a few seconds to respond. This is standard stuff. Like, these are stuff that you encounter all the time when you see randomized trials. And it's practically always these trials. They will show you the table 1. They will show you these imbalances, etc. All right, we're getting more and more answers. Beautiful. I'll give you a few more seconds. Okay, I'll deactivate now. So 67% chose the second one. Nobody chose the first one. 67% chose the second one, and 33%, 1/3, chose the third one. The answer is the first one. And this is great news, guys, because if you knew the answer, then you would know nothing in today's lecture. So that means that today's lecture is actually going to be useful for you. So obviously, it's something that's unexpected. People do this error all the time, so don't feel bad. So why is this so confusing? Because very often we don't realize that random patterns come in clusters. So this is a random pattern. Was made, using a random pattern. You see how it clusters? This, which looks more homogeneous, more balanced, is actually non-random. You can literally go to random.org and ask it to do a random coin flip sequence, heads versus tails. I did it, just for this example. You see head, tails, tails. See how it clusters? Tails, 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 how it imbalances, So you see randomization actually is meant to imbalance things. In fact, the confidence intervals, the standard errors for the comparisons that we get between groups assume that there will be imbalances. They're meant to have these imbalances. This is why, literally, the practice of seeing such imbalances in baseline variables in table 1 and concluding that these imbalances compromise these inferences, which these inferences literally assume that they're going to be imbalances, has a name. It's called the table 1 fallacy. So we actually did look it up in phase 3 oncology RCTs in the past 20 years, I think. And we found that about 1/4 of it, 1/4 of them, would make this mistake. It is less likely to occur in trials made by industry and in larger trials, and interestingly enough, in trials published in European journals versus American journals. And as I mentioned, literally, the confidence intervals from the results of trials anticipate that there will be such imbalances. That's the point of randomization. But it is true, the instinct that people have that there is something off here is true, that because of these imbalances, randomized trials do not produce apples-to-apples comparisons between the cohorts. They're not meant to do that. In order to achieve what we call an apples-to-apples comparison, we actually need to balance. And so, as I said, this is the people that invented randomized trials, particularly Ronald Fisher, that invented randomized trials in agriculture. His philosophy was balance what you know to achieve the apples-to-apples comparisons for the things that you know and care about, randomize what you don't know. And as I said, why do you need to do that? Because the very definition of randomization implies that you will get imbalances for the things that you don't know and for the things that you don't stratify for. So now you guys will understand why we do something in randomized trials called stratification. Its other name is blocking. All of this come from agriculture, exactly. That's where these terms come from, exactly because randomized trials were invented in agriculture. And the point of stratification is to balance what you care about, to balance what we call the prognostic factors that can influence the outcome of interest, the things that you're interested in can influence the outcome. Why? What do you gain with balance? You gain better precision of your estimates. What does that mean? You get more narrow confidence intervals. So the randomization removes the systematic bias, resulting in more accurate, and I'll explain to you what the difference is, accurate inferences. Precision is different. So what is accuracy? Accuracy is the opposite of bias. So you have high accuracy, low bias. Accuracy is essentially measuring the trueness. It answers the question, is my inference for the comparisons true? Another name for accuracy we use sometimes is patient relevance. So randomization is what we call a causal concept that helps with accuracy. It answers the question, was choosing one strategy over another the cause of the better outcomes? And that's different than a non-causal statistical concept named precision, which is a statistical concept that measures the variance in our inferences. It answers the question, how close to each other are my estimates from the comparisons? Another name for this is robustness. A related term is power. Higher the power, higher the precision, more narrow your confidence intervals. And this is the trick practically for you guys when you read trial results: wider confidence intervals, lower precision. Higher precision, more narrow confidence intervals. If you balance prognostic factors via, for example, through stratification, also known as blocking, you will increase the power, you will increase the precision, you will get more narrow confidence intervals. So this is the difference between accuracy and precision. This is an example of a randomized trial. So you get accuracy with balanced prognostic factors, so you get less dispersion. This is an example of, let's say, a very confounded trial. Let's say it was a big observational study where we didn't account for confounding, but it was a very large study, so it had a lot of power, so a lot of precision, so it's here. This is an example of a randomized trial that was, though, very, very, very imprecise. It could be because it had imbalanced prognostic factor or low sample size or whatever, so that's why you see the dispersion here. And this is an example of something that's not accurate nor precise. These are two separate orthogonal concepts, one of them influenced by randomization, the other one influenced by balance that we need to include in the design by choosing the right stratification factors and adjusting for it. So the other important thing, you all know this, that effect sizes are very important in oncology. And the confidence intervals for the effect sizes, again, tell us the precision of the study. This, what I'm saying here, is not strictly correct. Technically, they don't exactly measure the precision. Confidence intervals are a very, very, very difficult concept. It would take me at least an hour to explain what confidence intervals are and what they measure. And I'm not going to go into it. I just want us to learn how to use them in practice. How do we use them? Every time that we see them being narrow, they're precise. Every time that we see them being wide, they're imprecise. Now, what are confidence intervals? This is the formal interpretation. If we repeat the exact same clinical trial an infinite number of times, 95% of the trials will include the true value within the confidence interval, assuming that all the assumptions used to compute the intervals are correct. What the hell is that? It's impossible to intuit. You can visualize it. The fact that I even believe that this is teachable within an hour, some people would not agree with that. Some people would say it will take years to even understand what this is. But practically, the point is, when they're narrow, we have a precise trial. When they're narrow around 1, like let's say the hazard ratios include in the confidence intervals, they have values between 0.9 to 1.1. We very often consider that to be not clinically meaningful difference conventionally. A way to be very accurate when you try to express confidence intervals and what they are is to use this term, compatible. So that's what it is. The confidence intervals certainly do not, what the values that is within them is not there with 90%, 95% probability or something like that. It's not. What happens is that the values that are within the confidence intervals are compatible at the 95% level with values as low as, let's say, 0.9 or 1.1. That's it. You use the term compatible and you will be okay. So now, when we look at it now in practice, which confidence interval from this one would be imprecise and what we call inconclusive, you can tell it's this one. Why? Very wide and compatible with clinically meaningful effect sizes, hazard ratio of 0.7, 0.8, but also clinically non-meaningful effect sizes and even a little bit above 1. So what conclusions can I make from a study that gives you this confidence intervals? Nothing, because it could be clinically meaningful difference in favor of the treatment, but it may not be. And here, let's say you want a precise that suggests no meaningful difference. That's the one. You see, it's precise because it's narrow, the confidence intervals, and the results are compatible with only very, very, very tiny effect sizes. So that's why no clinically meaningful difference. And here is an example of something that's precise. Again, narrow confidence intervals and compatible, the values within it, only with large effect sizes in favor of the treatment group. So that's it. So now when you look at a trial like this, you see that, it's a relatively, precise, not too precise study, but the values within the confidence intervals are compatible with effect sizes in favor of the LRT group. If we balance, so that's more like this, if we balance even further, we may get more precision and make them more narrow. If the people that designed this trial cared about this, they should have, in my opinion, then they should have made sure that they would get the balance that they need by stratifying and, more importantly, by adjusting in a regression model. Actually, adjusting in a regression model gives you more precision than just stratifying. So this is what I just talked about, that if you want to balance, you either stratify or they're not mutually exclusive. You can adjust, and then you get adjusted hazard ratios. In oncology, often the equivalent is something we call the stratified hazard ratios. Those are, again, ways to adjust. And why do we adjust? To improve our precision, to get more narrow confidence intervals for our inferences. And so this is, if you go to the JAMA Guide to Statistical Methods, if you now that you're able to read between the lines, when they say that when you randomize, there are no systematic differences, they're right. It improves your accuracy, but there will still be random differences. You see what I'm saying? Because of the imbalances that it will give, and you can read more about these random differences here. And now you can also understand why the FDA and the EMA say adjust. And now you know what that is, for important baseline characteristics that you think will have a prognostic effect. You may now intuitively realize that, hey, if these regulators are telling us that prognostic effects are so important in the trial design, why wouldn't they be important when we make clinical decisions? Of course they are. Prognostic effects and things like the IMDC, for example, or MSKC prognostic score are extremely valuable both for trial design and clinical decision making, much more likely to be useful than the so-called predictive effects as we have known for almost 100 years now. So in this breast cancer trial, what they did is they also saw the forest plots. We love looking at forest plots in oncology. And one of the things that they didn't do, and a lot of people consider to be best practices, including by the Lancet, is to show the overall effect. So what you really care about when you look at forest plot is not this vertical line around 1, like pointing to 1. It's this vertical line that comes from the overall effect size. And if the various subgroups, their confidence intervals show that the various subgroups have results that are compatible with the overall effect, then you're not seeing any difference. And here is a way, we give examples of how to interpret various types of various scenarios in forest plots, and you will see that a lot of them can be inconclusive if they're very wide confidence intervals. And so the values for these results are compatible with very, very different effect sizes, then you learn nothing. It's noise. It's inconclusive. We actually looked this empirically, looking at the ASCO forest plots in 2020 and 2021 with Andy Hahn and Nasli Disman. And this in these conferences, there were a total of 99 forest plots that were presented, and only 24 out of all these forest plots, only 24% contain at least one subgroup that might have implied that there was some treatment differences. If you look at these forest plots, we were able to even get more information to be even kinder to them and see if instead of showing differences in subgroups, they showed homogeneity. And we looked at 1,300 subgroup analysis that they did, and 57% were inconclusive. That's the equivalent of noise. That's the equivalent of nothing. You're not learning nothing. 40% of them suggested that each subgroup was the same as the overall effect, so you learned something, and that is that there was no difference. And only 1.6% showed that there was potential evidence, with all the caveats we always have, of treatment effect heterogeneity. So every single time you look at forest plots at ASCO, GU ASCO, or at phase 3 as it is in oncology, keep that in mind. Most likely, you're not going to see a treatment effect heterogeneity. They will either be inconclusive, meaning noise, or they will show treatment effect homogeneity. Peter Thal, one of our preeminent statisticians at MD Anderson, when he saw this data, he gave this quote to us. Again, expected. Now, another thing is the following. Everything that I'm telling you, it has been known for a long, long, long time. And in fact, in 2019, I was one of these 800 people that we wrote this commentary that was published in Nature. And we said, hey, let's stop, first of all, making what we call the mistake of dichotomization, where we say significant versus non-significant, because people make the mistake of looking at this, let's say it's a subgroup analysis, or these are two separate trials, it doesn't matter. And essentially, those two results are the same. It just so happens that this result in red is much less precise, so it's compatible with a lot of different values, but it's certainly compatible with this result. And it was shown in this paper that about 50%, 51% of articles in various journals get this wrong. They get this simple fact wrong. They get this interpretation that now you guys know how to do it wrong. And so this is important.
Hey,
and
Pavlos, can I interrupt
yes,
for a question?
Absolutely.
If you just go back. So my understanding is a lot of people have interpreted this paper to say we should get rid of p-values altogether, but that's not really what it's saying.
No.
It's just saying don't over-interpret the p-value, and there's nothing magic about 0.05. Is that fair?
Absolutely. And in fact, since I was one of the people that cited it, I can tell you, for example, Sander Greenland has wrote an article explain the value of p-values. So it's not, they have a lot of limitations, but no, absolutely. The point of this article was initially to be quantitative, that exactly there's nothing magic about 0.05. We did learn in the following years in practice that, busy clinicians still need some guide. And what we ended up believing these days is that it might be better to trichotomize. So think in these terms. Instead of dichotomy, which was the point that this article was against, think in terms of trichotomy. Meaningful difference, no meaningful difference, noise. With that trichotomization, you follow exactly the spirit of that article. If you use that little trick, we'll be okay, because it immediately tells you that this is not just no significant difference, because a no significant difference could be that you're getting a signal of no meaningful difference. That can give you a large p-value as well. But you can have a large p-value when you have noise, very wide confidence intervals. Absolutely. That's a great question. That's exactly the spirit. A lot of people got this wrong, exactly as you said, thinking that somehow we were against p-values. We're not. We're not. And so this can help us interpret what is also happening. It's the same kind of thing with the adjuvant immunotherapy trials in RCC. You see here all of these trials, which, when we meta-analyze, you see that they're all pointing in the same direction, that there does appear to be some effect with adjuvant immunotherapy is just not very strong. But there is some effect. And so a lot of people, made that mistake of dichotomizing, and they said, oh, the other trials were not significant, so they didn't show a difference. No, they just were inconclusive because they had very wide confidence intervals, as you can see here. And they started saying, oh, is there a differences in efficacy in the adjuvant setting between nivolumab and pembrolizumab? They're literally the same drug. Is there a difference in duration of therapy? I don't know, maybe. Was there a difference in inclusion criteria or the fact that they had clear surveillance, clear histology? Sure, anything could be, maybe. But we need first to start with first principles. What are we actually seeing? We're literally seeing all of these results pointing in the same direction, but one trial happened to be much more precise than all of the others. And here is the trick that is not discussed among academics, that the fact that one of these trials had the highest precision, meaning the narrow confidence intervals, which was due to its increased design power, it was by design. It was not a coincidence. And we've written commentaries explaining that you can literally see here that in the design power of Keynote 564, by far it was higher for Keynote 564, but there's another trick that Merck likes to do. What is the problem in the adjuvant kidney cancer setting that we don't have, let's say, in bladder cancer? It's a good problem to have, that kidney cancer doesn't like to recur as much. We have less events in the adjuvant setting. It's kind of like with hormone receptor positive breast cancer. When they do adjuvant trials there, they need thousands of patients because of the low signal to noise ratio. Same in the adjuvant kidney cancer setting. We need a lot of patients to detect signals. So you really, really need to power a lot the trials. And if you compare the metastatic setting versus the adjuvant setting, you have way more events in the metastatic setting. So if you are going to do an adjuvant trial, you need a higher sample size by definition than in the metastatic setting. But having said that, look at Prosper, which used nivolumab monotherapy, versus Checkmate 2 and 4. They actually they targeted less number of patients than in the metastatic setting, even though you can see by the number at risk at 2 years how much higher density there was in the metastatic setting versus the adjuvant setting, because people don't recur as much. Same with these trials. Same inversion. Same here. The only one that didn't do this was actually the Keynote trial, and they don't just do that in kidney cancer. This is something that Merck has been particularly careful with, apparently, with a lot of their pembro trials. They do seem to be a little bit more wary of these principles. And so here I have now, once you understand these principles, you can do a little bit of magic. This you don't have to get right. This is one of the fun parts, but it will help you build intuition. Let's say that we try to replicate exactly Keynote 564. These are the results that it got for DFS, the latest ones in 2024. If we try to do the exact same trial, same sample size, same population, same whatever, eligibility criteria, and based on our prior experience with oncology phase 3 RCTs, what is the most plausible probability that the final analysis of the second trial would show efficacy in the disease-free survival endpoint in favor of pembro with p less than 0.05? 100%, 95%, 75%, 50%, 25%, 0%, or are we asking for the impossible? What do you guys think? Just intuitively, just for fun. I'll give you a tool that you can actually start answering in an evidence-based manner these questions. All right, so people are still answering. All right, so I'm gonna deactivate it. Remember, it is true. It was powered 95%. So 56% think 95%, and then 22% thought 75%, and then 11% thought either 50% or 25%. The answer is actually 75%. And we actually have a web tool that you can literally put the endpoints of phase 3 RCTs in oncology, and it can give you this type of probability. The other cool thing is it tells you that if you doubled the sample size of the replication study, what would be the probability will get you less than 0.05? It still is not, 95%. You will need to triple the sample size. That's how difficult and challenging the adjuvant kidney cancer scenario is, to be able to be certain to have enough confidence that you're going to get a p-values of less than 0.05. Isn't that crazy? Now, our whole RCT system made by the FDA, whether most people there realize it or not, it actually is tailored to help you correctly identify the direction of effects. They really, really don't want you to approve, let's say, a drug that does the complete opposite of what it's supposed to do. So you can see here that even with the simple results of Keynote 564, we have a very good probability of correctly identifying the direction of effects. Not exactly the effect size, that would require much, much higher sample size, or including, you see, even the probability that the 95% confidence intervals cover the true effect is definitely not 95%, neither for Keynote 564, nor for many other trials. But the directionality is there. That's what they're doing. Now that you know, by the way, and I'm almost done because I want to give you guys time for questions, is now you know how to interpret, for example, this trial. In upper tract urothelial carcinoma, some people, this is a forest plot shown in the Lancet. Some people said, oh, look at this, lymph node positive, adjuvant chemotherapy versus surveillance, lymph node positive, touches, crosses one, and whatever. And so that means that we shouldn't give adjuvant chemo in lymph node positive. That's insane. No, what happened is, now you know how to read it, lymph node positive, very, very, very wide confidence intervals. Why? Very few events, very few patients, noise. There's nothing here. Nothing to see here, nothing, no predictive effects from this subgroup effect. I don't have the time to teach you how to use the prognostic effect, the fact that lymph node positive gives you worse prognosis. And what happens is, this is a standard assumption on the primary endpoints of RCT, that the worse the prognosis of somebody, the more early benefit you get. And so you forget the forest plot. This forest plot is completely conclusive. Whether you show it to somebody or not makes no difference, because you see how inconclusive it is. And so you can see here, when we wrote an article talking about these things, Gordon Guyot, who wrote a commentary on what we're saying, he is the guy that came up with the term evidence-based medicine in 1991. And he says, same old, people keep doing the same old mistake. But no, I think that we can actually get better, and we can actually learn these methods and these nuances to interpret these things in a better way. And another thing, again, I'm not going to go too deeply into it, but it's important to realize that the so-called predictive effects that forest plots are looking to detect, they're very hard to detect statistically. On average, you need 16 times the sample size that you need for the primary endpoint, which no trial really ever have. This is why the so-called predictive effects, the biological interactions, are typically identified in the lab, and then you can use other studies, clinical studies, to validate them. But what happens is, there is this selection bias when the predictive effects are super strong, and we see them like, oh, they're amazing. But in the vast majority of cases, predictive effects are notoriously very, very weak. We've known this since the time of Harold Jeffries in the mid-20th century. Whereas prognostic effects are super powerful. That's why we account for them by stratification in randomized trials. They're always strong enough to make a difference in how you manage a patient. And this is why Jack Cusick, he's been analyzing trials in breast cancer for almost half a century. And you can see here, treatment interaction is a different term for saying predictive effects. And he says there's somewhat confused belief that, you need to show a predictive effect for something to be useful. No, it's not. And we've written a lot about it. And in fact, literally, Maria Carlo and Dan Shapiro led the IKCS North American think tank exactly to describe and delineate for the kidney cancer world how to take it into account and take advantage of prognostic effects. There is a lot of immense untapped potential there that hopefully we will be taking advantage of more and more. But the point is, you can see it even in this forest plot where prognosis plays a role. If you have lymph node positive disease, forget about this forest plot. It doesn't tell you anything. Zero information from this one, but you get worse prognosis. You know that somebody who has lymph node positive disease has worse prognosis. prognosis, so they get a higher 6-month absolute risk reduction. And so you give adjuvant therapy. Harvard Data Science Review had asked me to, again, show this idea of the dichotomy and help also on how to read survival curves. And remember, the problem with survival curves is that they give you this mistaken intuition that the point estimates shown by the survival curves are crisp. They're in fact noisy because of the uncertainty, and focusing just on the survival curves amplifies that noise. What you need to focus on is the uncertainty, the confidence bands. And one trick, and there is, this package in R that can help you do this for any survival curve, is you can, focusing on the differences, you can generate this gray polygon throughout the plot that shows the uncertainty for the differences in survival. That, as we said, that's what RCTs are all about. And when you make this polygon, this gray thing, and it is narrow and does not touch the survival curves for the two groups, then that is indicates a difference. This I simulated. I told the simulation in R, and you can find the code in the Harvard Data Science Review article I wrote. I said, make me survival curves for a big difference. And it gave me, for example, this one with this hazard ratio. Okay. Then I asked it, make me survival curves for no clinically meaningful difference. You see here, the polygon is still narrow, but it touches, overlaps with the survival curves. There is no clinically meaningful difference. And then I asked it, this is the simulation. I make the rules here. I asked it, make me noise. There is no signal. This is nothing. This is like complete, like if I showed you a white figure, like completely blank, it's the same thing. Give me noise and turn that noise into survival curves, and gave me this. The way to know that it is noise is, first of all, by looking at the hazard ratio, very wide confidence intervals. And if you want to just look visually at the survival curves, notice how wide the polygon is. And then people make the mistake of saying, oh, what is happening, let's say, at the tail end of the curves? Nothing, guys. This is noise. I literally made sure that this is noise. There's nothing to see here. It just so happens, if you play around with this code, you will see that noise often likes to behave like that. And this will help you. This is one of the final slides. Look at Cosmic 313. Now you will be able to interpret it. Look at, a lot of people looked at this and they said, oh, something is happening in the poor risk group. There is no significant difference. You no longer dichotomize like that. You think more crisply. In the trichotomy setting, you know that the results were inconclusive because they're noise. But a lot of people said, oh, no significant difference. So somehow in the poor risk group, you're getting worse effect. And then people started saying a lot of ideas, which they may correct or not. It is a more toxic regimen. But the important thing is to be supported by the actual data at hand. And of course, this is noise. And it literally looks very similar to this, which I know is noise because I made it to be noise. And you know that it's noise. Why? Because they had few events. It just had. So there's no reason to even look at this. This is just noise. So there is no evidence to support that there is a so-called predictive effect. Predictive effect is a difference in the hazard ratio scale. That's what forest plots and things like that are trying to do. And I told you, they're typically weak and notoriously difficult to detect. But per the prognostic effect, and you may agree with this assumption or not, but that's literally the assumption made in the primary endpoint analysis of Cosmic 313. Behind the math, they made the assumption that if you have poor prognosis by IMDC, you're going to get more early benefit, which, by the way, fits with intuition that if you have somebody that is super sick, that they're only going to get one therapy in their life, you want to give them, more drugs if they can tolerate it. That's the assumption in the primary endpoint analysis. So that's it. In summary, medical trial randomized trials can validly estimate the uncertainty of comparative metrics of differences, such as hazard ratios. They cannot as easily estimate the uncertainty of group-specific metrics. You need to make a whole lot of assumptions to come up with valid confidence intervals for that. Imbalances between subgroups in RCTs reduce the precision. That's why we stratify and we adjust for prognostic factors to increase the precision. Randomization alone will not take care of that. Prognostic effects are typically stronger than predictive effects. That's why we care about them so much when we design trials and in clinic. And it helps to replace significance and non-significance. ideally we would be fully quantitative, but we're all busy clinicians. So at the very least, we can use this very efficient trichotomy of difference versus no clinically meaningful difference versus noise. That's it. Thank you guys for your kind attention, and happy to answer any questions.
Thanks, Pavlos. That was great. We have a few minutes for questions. I have one for you before people chime in. So early on in your talk, you said, when people have a hazard ratio of 0.7, almost every time from the podium, people will say there's a 30% reduction in the risk of progression or death, depending on, the curve. But I know that's not correct. So my question is there a correct way to say that? Or should people just be avoiding it altogether?
Great question. And in fact, one of our patient advocates, Katie Coleman, has made this calculator that allow you to turn hazard ratios into actual risks. And if you play around with it enough, you will see the difference between a risk and a hazard. Hazard ratios tend to overstate the reduction in risk. That's why it's better not to use the term risk. Most people think of risks as probabilities, and as I said, hazards are not probabilities. The easiest way is to just say 30% reduction in hazards. It's a ratio of hazards, so a 30%, that's it. A 30% reduction in risk is a risk ratio. You see what I'm saying? Yeah. A 30% reduction in odds, it's an odds ratio. So we stick to the actual name and we're okay. And it does make mathematically, when you actually estimate the actual risks, it does make a big difference if you use that calculator. That's why it's particularly important that we stay to the terminology.
Thank you. Other questions from the group?
This is Ritesh. Obviously, great talk, Pavlos. Do you mind going back to that slide on the adjuvant data? I'm just curious, going through how the different studies were powered, and maybe Brian, you'll have a little bit of insight into this, but it is interesting to see how that one is so different. I guess so much more precise. I guess maybe precise is not the right word there, but
it is.
And again, look at this.
Because we obviously always debate like PD-L1, we debate exposure, we debate so much, but we never debate the statistics of the trial.
Exactly. Look at what Merck did. Look at what they did. The trials they cared, like in Pembro AKCI, Keynote 426, 99% power. Do you see? And in Keynote 564, 95. You know how a lot of people are like, let me do an 80% power or whatever. They went for 95% in Keynote 564. To get to 99%, they would need way more patients. And, they have to be pragmatic. But in the metastatic one,
Do you remember when Checkmate 914 was, like, before they split into Part A, Part B, it was just Ipi-Nivo. Was it power? Because, like, they changed it during to compete with 564. But do you remember what the power was on the original design of that study? Was it better than 90%?
I don't think so.
No, they never did. In fact, they did another mistake, which even a mistake. It's not a mistake. These are things. But what would reduce their power even more was the fact that they randomized, if I recall correctly, 2-1. Which reduces your power even more. So these things, as you can tell, precision makes a big difference. You can tell that everything, it's not like any of them really, shows that, goes above. You get the most imprecise ones and it goes all over the place, but that's because they're very imprecise. But when
was like thinking like you look at 914 Part B on that plot, it's sort of interesting to see maybe like, if that was a shortened interval, but PD-1 only, so to speak, like would you with more power, you have seen like a halfway point to 564 is half amount of drug, so to speak, right?
Yeah, when we wrote these tables, when we published them with Dan, Part B was not out. So I included it here in the forest plot so that you can see it. But I'm pretty sure I looked it up, and we can update obviously those tables, and it's still not even close to the 95% of this one.
Got it. Okay. Yeah.
And if you look, go to the forest spot, if you will, Pavlos. For 564, it's not only more precise, but the point estimate is lower, obviously. Right.
So,
beautiful. So, again, why is that the case? I don't, probably the other things that you mentioned.
No. This is beautiful. I'm so glad you asked this. So I'll tell you one other trick. I will put it on the chat. And it's not just us that show this. I will show it so that others can see it, in the video. This is where we show that, oncology trials, are being criticized a lot. And we have our limitations. We talked about it. But the reality is, and we showed in this paper in JCO Precision Oncology, that if you look at the signal-to-noise ratio as a measurement of the quality of oncology trials, it's actually on average 3 times higher than the average medical RCT. And how do we know this? Because one of our collaborators actually analyzed the whole Cochrane data set of RCTs, and he published this in the New England Journal of Medicine Evidence. This is the analysis of all the medical RCTs. And you will see the signal-to-noise ratio, meaning the power is depressingly low there. In oncology, our actual power ends up being around in the range of 50%, 45%. I don't remember the exact number. So it's not like in the 10 or 15 or 20% rates that you see in other medical fields, but still that actual power, remember, the 95% is the design power, what you intend to do. What you actually get on average tends to be less. And when you have less power, that increases the exaggeration. So in the vast majority of phase 3 RCTs in oncology and throughout medicine, if you rely only on one trial, your result will be exaggerated. It's the so-called winner's curse. In fact, we've made an app, this is the app, where you can literally crunch in the results of, let's say, Keynote 564 to shrink the result to take into account that exaggeration, and then you will get to something a little bit closer to the meta-analysis result. So every time you look at one trial result alone, if it's positive, meaning low p-value, it has increased likelihood of exaggerating its result because of the winner's curse. Because as I told you, that's exactly why I showed you guys the probability of replication. Even in this design of the Keynote 564, if we completely try to replicate it, we still might not get that p-value of less than 0.05. Even, you see?
Pavlos, this is great. We're running out of time, but just reminds me how much statistics I don't actually know. So thank you for that reminder. So we may have you back for part 2, but I really appreciate your time, and thanks everybody for attending. We'll see you next month.
Thank you so much for the kind invitation, guys.
Thanks again, Pavlos. That was great.
You. Bye.
Yeah.
Thank you, Pavlos.
Appreciate you.
Thank you, Pablo.